Good morning again. Thank you all for coming. So this is going to be interactive, so welcome even audience to participate when we have the panel discussing this. So we'll be taking sort of a case-based approach here. So we'll go over a little bit of introduction and then we'll go over some cases. So during this talk, we'll try to define the spectrum of cardiogenic shock, choice of support, looking at indications and contraindications, the hemodynamic benefit with various medications and devices, the clinical benefit, both observational and some randomized controlled trials, and lastly, we'll be talking a little bit about the multidisciplinary approach. So I think this is one thing probably everybody can agree upon is that cardiogenic shock is associated with poor prognosis. So as you can see in one of the earlier studies from 1999, as you keep increasing the number of inotropes and add vasopressors, your mortality continues to increase to about 80% as you go through the spectrum of shock. And it's again represented well with the Intermax profiles. As you go up the profile, your survival really decreases. So one of the things that I wanted to go over was just looking at profiles of cardiogenic shock so that we are able to actually identify, which profile patients fit in and, what we could offer them. So as we go through the spectrum, we start off with precardiogenic shock, which is essentially defined as hypoperfusion without hypotension. So you have a patient who has cool extremities, oliguria, hemodynamically significant where, pulmonary capillary wedge pressure is greater than 15 and cardiac index less than 2, but the patient does not have hypotension, which means systolic blood pressure is over 90 millimeters of mercury. And then it's over cardiogenic shock where you have hypotension with hypoperfusion. Again, all symptoms of hypoperfusion, which were present in precardiogenic shock, but is accompanied by systolic blood pressure under 90 and a mean blood pressure less than 30 millimeters compared to baseline, and a need for a balloon pump or an inotrope. And then you go into severe refractory cardiogenic shock, which is hypotension with hypoperfusion despite support, where despite all the things that you're doing to treat cardiogenic shock, you continue to have hypotension and evidence of hypoperfusion. So this is, sort of the cascade which occurs in, in cardiogenic shock. And as we go through here, when you begin with either myocardial infarction or progressive myocardial dysfunction, you get both systolic and diastolic dysfunction leading to decreased cardiac output, decreased stroke volume. But also, of note is that we are recognizing more and more is this presence of systemic inflammation, which is what truly characterizes this refractory cardiogenic shock, where you really have more of low SVR syndrome, where you really are more behaving more like sepsis rather than true cardiogenic shock, which is associated with high systemic vascular resistance. So I think we'll start off with our first case. So this is a 59-year-old Caucasian male with ischemic cardiomyopathy on medical treatment for 5 years, who's had NYHA class 3B or 4 for the last 3 months. He's had 4 hospitalizations in the last 1 year, so he's already in advanced heart failure. Presence to the ER with 4-week history of progressive shortness of breath, even at rest, orthopnea, mild leg swelling, and a cough. No chest pain. We started on IV diuretics, followed by an inotrope by the admitting team because they felt he had evidence of, hypoperfusion on exam. Again, no fevers, no chills. Remainder of review of systems was negative. The past medical history is significant for ischemic cardiomyopathy. Baseline LVEF less than 20%. He's had a history of coronary artery disease, but his last angiogram did not have any intervenable lesions. He already has an ICD, and as a preparation of for transplant and workup for advanced heart failure, he's had a outpatient CPET which shows an MVO2 of 9.5 with a VCO2 of 40. He has the other comorbidities including hypertension, dyslipidemia, AFib, and chronic kidney disease. He's on some heart failure medications, mainly off of ACE inhibitors because of intolerance. He's tolerating a low dose of hydralazine and isordil, again, mainly because of chronic kidney disease. He's on aldactone. And on initial physical exam, so we were consulted next, and he had a blood pressure of 90 or 55. His BMI was 30. His heart rate was 60. He was BIV paced, and his oxygen saturations was 94% on room air with a respiratory rate of 22. Again, he had an S3 gallop with a systolic murmur of 2 over 6, heart at the apex. No ascites, abdomen was soft, and he had, he was cool to touch, and 1+ pulses throughout. Since we watched him, we came in on day 2, and after the initiation of milrinone and diuretics, we watched that his creatinine worsened over the next day or so, with this creatinine going up from 1.5 to 2.4. But his other end organs, like the liver, was okay. His albumin was mildly decreased. And troponin was mildly positive, suggestive of acute decompensated heart failure. And again, we completed his transplant workup, which showed, unremarkable serology. And he was an ABO blood type O. So looking at his echo, is a markedly dilated LV with 7.2 centimeters. As you can all see, the RV function seems to be reasonably okay here, maybe mild dysfunction. Left atrium is definitely enlarged. And we took him to the cath lab. This is on all his invasive hemodynamics were done on milrinone. Showed a right atrial pressure of 10, wedge pressure of 34, and a cardiac index of 2.1 on milrinone. And again, his PA pressure was 68 over 35 with a mean of 46, so his TPG was 12. So that gives him a PVR of under 3. So in assessment, this is a patient who has progressive systolic heart failure with low cardiac output stage, who is admitted with acute decompensation and on inotrope, continues to have persistent end organ function. He has coronary artery disease without unstable angina, and he's got secondary pulmonary hypertension. So my question to the panel is, what's the next step? Would you add norepinephrine to milrinone? Would you add, give him an intra-aortic balloon pump? Would you directly proceed to a durable LVAD placement, whether as a bridge or destination therapy, or should we consider even more robust temporary mechanical circulatory support, such as an IMPELLA or a tandem heart device? Dr. Torre?
So I'm anxious to make a comment. Because I'm getting progressively tachycardic here. Is this working or not? No.
Huh?
No, but you can hear. Anyway, so I think that the fundamental problem, and this is an important question to address, that this patient is trying to die. He's telling everybody that wants to die. 4 admissions to the hospital without paying attention, I think is that, where somebody has to intervene. Right, so by the time it comes now to the hospital, he's been trying to tell everybody, the wife, the doctor, the primary care physician. So these patients need early intervention. So we're going to discuss shock, but I think this shouldn't come to this point. 4 previous hospitalizations, somebody who has bad EF, end-stage coronary disease, I don't know what else you need to do. There is certainly no debate there. That patient should have been brought to the attention of the heart failure transplant team earlier. So now he's very sick, and there's probably, I have some views, but maybe Mark. I think it's really important for everybody to understand that part, even more than what we're going to do with the patient today. I think one has to do preventive medicine, and I think that would be my important comment. But
I too am tachycardic over here. He's calling out for help and no one was listening, essentially. And if you go to the heart failure guidelines, there's kind of simple clinical clues that were put in there, a table to identify patients with advanced heart failure, hospitalizations being one, but circulatory renal limitation to ACE inhibitor. It came off as ACE inhibitor because it was hypotensive, worsening renal function. These are all simple things that everyone in the room could easily identify. You don't have to hear a soft S3. This is just looking at very obvious facts. And he was calling out for help, and we didn't hear him. Let alone his CPX was atrocious as well. So I would echo those comments that earlier intervention, I think if I'm in this room and I'm in your seat thinking about who do I need to refer to advanced therapies, these are simple clues that I would definitely want to know about.
So I would say that's going to be a nice topic and addressed in the afternoon session. Our reality is that we see no shortage of shock in the ER being called at this time.
Yeah, so Brian.
Points well made, will be addressed. What are you going to do?
So here, I mean, it's in the cath lab.
Hold on, Guillermo, just 1 second. The surgeons are also tachycardic. Why did you let this patient get so sick and then jump on my doorstep? Okay, but go ahead, Guillermo.
He's
Sorry.
not in the doorstep yet. So, I mean, he's in the cath lab and he's talking to you, I suppose, still.
Yes.
The numbers look terrible. First thing I would do, I put an intra-aortic balloon pump. It's not a big deal. But I don't think that's the fundamental question here. Because I think what you want us to, or I don't know the case, but what would probably happen is that despite the balloon pump, you're not restoring a state of good hemodynamics or good perfusion, and then that would be the next question. So I would put a balloon pump, but then I think you need to do something else.
So I guess, following up with your comment, at this time, if you had a choice of, putting a balloon pump first, or you have a surgeon who wants, who is available to put in a more robust support, what would you choose?
So the problem with more robust support is that I think, in general, you need a conversation with the patient to understand what he wants. Now, the patient didn't do much, was in the hospital 4 times, this wasn't addressed. I think the commitment to do a more permanent form of support.
More temporary, whether, you're looking at...
yeah, so sure. Yeah, sure.
So here we got a challenge. So you're going to put a balloon.
Yes.
That's great. I think we get a lot of support. What are you looking for? What's your timetable to understand response, non-response?
So you continue to pick on me, so I'll take it. And then, so I'll put a balloon pump, I'll put the patient in a position so that we can have a conversation, get the family around. There is no question he has end-stage disease. I think the fundamental question on the long term is he someone who's going to be a good candidate for long-term VAD or transplantation? So I think my next decision should be based on that context. So if today you had the answer and you know that this patient would have there would be a great candidate, psychosocially, financial, all of these aspects, then I would have no hesitation in doing an IMPELLA 501, have Brian put in a graft and throw it IMPELLA, or Eddie. I think I would not have a problem, but I think I would want to answer that question before you make a more significant commitment. If you have an opportunity, that's what I probably
So we'll hear from Eddie.
So you have time. This guy has been become something over the last 2 days. He's not emergent. And he's a pretty big guy, like 6 foot and bigger, and he's got really bad advanced disease already. I doubt the aortic balloon pump is going to make his kidneys come back if you're already on support. It may. But I do think the IMPELLA is more...
So should we give a balloon pump a choice, a chance, or should we just...
But I mean, if you have time to put in something that's more robust and is going to give him the cardiac output he needs and probably is going to give him a better chance at recovering his kidneys sooner, you may recover from it and be able to take it out. You don't have to commit to doing a permanent LVAD when you're putting an IMPELLA. It's just a more robust support that I would put in a bigger man that needs an aortic balloon pump. If you can, I would put in a 5.0 on this gentleman, and we just have that ability here. I would go ahead and it's a simple procedure where you do an incision underneath the clavicle, access the artery, and put in a small catheter. It's as big as the intra-aortic balloon pump, basically.
Dr. Drasner would like to get your...
I mean, clearly we're in a data-free zone here. I think I probably would start with a balloon pump and then escalate in general. I think the CPs and the 2.5s are not going to give you enough support for the real deal, and you're probably going to end up choosing in our center either a tandem or a 5.0 or VA ECMO if he continues to deteriorate. I don't think he's there yet. I'd probably try a balloon pump and see what we get. I'm not sure if he's been worked up yet for VAD transplant in terms of...
He has been pretty much completed most of it, yeah.
And then the question is, what is the timing of, depending on your center, how long it's going to take you to get a heart, whether you're going to have to go to durable VAD rather than try and directly transplant him. And then it would be, hopefully get him a little more stable, but don't sit on him too long, get him to durable VAD.
So let's say you were in a center where you would get a heart, within a week. would you consider putting him on, there's still, some centers which still try to, put patients on 2 inotropes. So, would you ever add, norepinephrine in this guy and put, give us one and try to do that versus choosing any mechanical option?
So in other words, is number one or medical therapy
If-
out of the equation?
Is it completely?
Perhaps for him, or are we all thinking at least a balloon, some consideration for IMPELLA prior to balloon, not understanding response and predicting response?
Yeah, for me, it depends on how sick they are, and just a judgment call about do you think you can get there with inotropes or not. I have a feeling he's not going to be ultimately, so I think he's going to need some type of mechanical support. But that's the type of thing where being at the bedside and additional data would help me make that decision.
Yeah, I also agree too, because you're playing a little dangerous game, so to speak. So you try your little norepinephrine and you'll get them to transplant really quick. If you don't, then they make it worse, and they're not a good surgical candidate for us. And I would say, I know Eddie's really big on the IMPELLA 5, so am I. I think this device has helped revolutionize our program. And we've actually bridged directly to durable VAD, and we're trying to do one even to transplant recently. But I think intraocular balloon pump would be the first step, and then go from there to durable VAD, and possibly IMPELLA if that fails.
I mean, just so people know, norepinephrine wouldn't be an option here. The kidneys, for me, already are showing they're ischemic. You add norepinephrine, you're going to make them even more ischemic. That's the thing. You need to, whatever you're going to do, if you're going to do something more advanced, you need to get them ready to go to the operating room. If you add norepinephrine, he's not going to get ready to get to more advanced therapy.
So I'll just extend the comment. It's not that norepinephrine may not be used, but it's not the fundamental strategy. I think that when you're dealing with a patient who is sick and has no pressure, you may add norepinephrine, but I don't think that's the key to the treatment, and I think that's what needs to be clearly understood. And the other thing is that inotropes in acute heart failure are damaging to the heart. I mean, these are therapy that we use to induce ischemia, and we can use it at a cost. The more you add, the more price that you're going to pay. So I think that this patient needs mechanical support, and we can argue VAD or IMPELLA, but balloon pump or IMPELLA, but clearly I think mechanical support is the answer.
So we'll go ahead and.
What do we do?
What did we do? Yeah, I guess the slide's not moving, but okay, here we have. So I'll just go over a little bit in terms of what things are available with us. We can put it through the axillary artery, and it stays in the descending aorta and does counterpulsation. And IMPELLA is really more of an axial flow device that you can put in the across the aortic valve. And the tandem heart is actually an extracorporeal device where the pump is outside, but you have a left atrial cannulation as the inflow and the outflow is in the aorta. And ECMO is probably the most complete since it also has an oxygenator along with it. So again, suggested indications for percutaneous short-term devices against severe heart failure in the setting of non-ischemic cardiomyopathy. This is guidelines from heart failure. So, like we were discussing, intra-aortic balloon pump is the most widely used, and again, indications would be for cath lab support, weaning from cardiopulmonary bypass, cardiogenic shock, ventricular failure. And really, it's sort of now class 2 recommendation to use it in cases of STEMI with cardiogenic shock, and in other indications, it's still a class 3 device. So just going over a little bit of theory of counterpulsation, it improves coronary perfusion, increases cardiac output, decreases heart rate, decreases wedge pressure, decreases SVR. It does decreases systolic blood pressure, but overall it increases the mean blood pressure. And it's because it increases the diastolic pressure. So again, overall benefits from a hemodynamic standpoint would be to decrease LVEDP and increase the stroke volume. So again, in terms of what intra-aortic balloon pumps are available, this is a sensation. They are linear. This has a fiber optic cable so that you can get real-time blood pressure monitoring. And there is a larger mega family of balloon pumps too, which provide for more blood displacement. So in terms of the actual data for intra-aortic balloon pump and cardiogenic shock, that is still limited because if you looked at the BCIS study, which really, randomized to elective balloon pump and medical in high-risk PCI. There's really no difference. And again, in the SHOCK 2 trial, there was no difference, one versus the other. Of course, both of these trials were really plagued by a lot of crossover. And in these kind of sick patients, when you have crossover, you really don't know what to make of the result. Both of them had about 10% crossover, so it makes it hard. This is some internal data that we have, which we have not published. Again, in about 25 patients, where most of these patients were, advanced heart failure progressing into sort of end-stage heart failure with cardiogenic shock, where we've shown that there is definitely improvement in cardiac output, decrease in mean PA pressure, and decrease in right atrial pressure, and again with improvement in end organ function. Now, one of the things that was brought about during the discussion is, when do you assess? How do you assess balloon pump, response? And in this study really sort of brought home the point that you can really assess that within 6 hours. If people respond to a balloon pump within 6 hours, their survival is so much better. So you don't have to wait for too long. You will know almost immediately that patients are responding to a balloon pump. So I just wanted to talk a little bit about our experience here, where we are able to put in balloon pumps through the axillary artery. For people who do the procedure, we first start off with brachial sheath and put in a wire as in the axillary artery as a guide, and then percutaneously puncture the axillary artery and place the balloon pump through the axillary artery. And again, Dr. Tor and Dr. Estep sort of pioneered this, and we've almost now put this in about 150 patients or so, and we've had reasonable success transplanting them. The big advantage with this is that patients can sit up and they can walk around with an axillary balloon pump, and they are not bed bound. And we've probably, our longest patient has been almost close to 3 months with an axillary balloon pump. It does, again, you see sustained improvement in end organ function, as we can see here. So coming back to our patient, after the balloon pump was put in, he really responded well. And I think that's one area where we really are not good at predicting, because I think we just don't know who responds that well to a balloon pump and who will not. And, I think we know in cases of refractory cardiogenic shock, where you have, really unresponsive vasodilatory syndrome, probably a balloon pump will not do much. But in these kind of cardiogenic shock patients, I think the jury is still out there in terms of who would respond and who would not. Any comments from the panel there?
If I may just say one comment just to guide the discussion. So in this patient, and he's responding to balloons, I would argue you want to know within a few hours, right?
Right.
Talk about what metrics you use to determine that. But as we're thinking about the heart allocation score, Dr. Dresser, in terms of where the balloon pump fit, do we need to demonstrate meaning? What's appropriate? You got a guy that had all the signals. Let's just say we as a group think he's better suited for a transplant. We're going to talk about transplant versus LVAD. And you have a favorable responder with all the milieu and background that we know, taking it out and trying to redo medical therapy, which has failed. How do we, as a community, incorporate maybe what's evolving in terms of balloon pump, extended support balloon pump? And I think it posed for some controversy in terms of at least active discussion. But in our experience, as probably perhaps in yours, there are some people that just respond favorably and are sufficiently ill where we're concerned of removing it, because I don't think we reset anything in terms of that projected poor prognosis. The comments.
Yeah, first I'd like to congratulate your group. The axillary approach, our center has started to incorporate that, and really based on Guillermo and Jerry's and the rest of the team's work. So that really, I think, made a big impact on the field. So I want to congratulate you on that. In terms of the heart allocation score, one of the key parameters is the patient a candidate for a durable VAD or not? Because you can imagine some centers could put in balloon pumps and leave their patients parked for several weeks, and other centers will be taking that patient to durable VAD. So at least we put in, you have to at least justify why the person is not a durable VAD candidate. The weaning parameters, there are some weaning parameters. You don't have to take out the balloon pump. You can wean it and show that they're still, I agree with you, someone like this is probably he was dependent before, he'll probably be dependent afterwards as well.
Any other comments? So Ashrith,
I think Brian.
Yeah, I have a comment. When you gave the history, he's been admitted, what, 4 times?
4 times, uh-huh.
I mean, this guy is end stage, and I think we need to go to the next step. So I don't understand why you want to remove the balloon pump. He needs to either go to transplant or a durable VAD or a bridge.
But, I guess, Dr. Rasner, I mean, I think we'll come to this point later, but one of the things that we often are challenged with is in somebody who is a larger gentleman with blood group O, you put in a VAD in that patient, he probably will, getting to transplant is going to be so much more challenging. You're going to wait for a complication, and that's something that we often,
Well, that's why not a durable VAD as a bridge to transplant.
just the waiting times are.
Yeah, the fundamental problem is we don't have enough hearts, and of course everyone wants hearts and not VADs, and so, but the problem is there just aren't enough hearts, so you have to kind of try and come up with some equitable way to allocate that precious resource. But yeah, if every person thought that way, then everyone would go to transplant without VADs, for sure. So I know what you're saying. It's a difficult situation because we just don't have enough hearts to go around.
So, we supported him with a balloon pump, and, then we took him directly to transplant, and he's doing very well post-transplant, and stable end organ function, doing well. So I think we'll go to the next case. This is a 41-year-old Caucasian male with a history of recently diagnosed heart failure in the last 2 to 4 weeks, and diabetes, hypertension, presents to the ER with 2-week history of progressive shortness of breath, with lying flat and at rest, no fatigue, no chest pain. He was intubated in the ER given his respiratory distress and started on norepinephrine given the hypotension, and no fevers, chills, and again review of systems positive for edema and redness over the past few days. He was transferred to the CCU. The heart failure service was called. Again, he has a history of non-ischemic cardiomyopathy, again diagnosed in the last 2 to 4 weeks, and at that time an outside angiogram reported normal coronaries. So history of hypertension, diabetes, history of back surgery. He was started on low-dose heart failure medications at that time, about 2 to 4 weeks ago, and now currently he's on DOPA, norepinephrine, dobutamine, and social history really, non-contributory. And on initial physical exam, his temperature is 99, blood pressure is 72 or 40, heart rate of 124. Saturation is 85% on this was prior to intubation. That was on room air, and his CVP is 20, and he has an S3 gallop, and he has edema. So till now, anything differently that you all would have done if you had seen this patient in the ER?
So I think we can all agree he's in more full work shock compared to the first case. So same question. I think yes, we can talk about maybe doing something earlier, getting involved early in this case. This is a reality for many. What are you going to do? Going through that same algorithm, at least in terms of decision making. We're going to want to understand long-term goals, but we want to support this young gentleman. Is they thought. What's your best next step?
Another comment that I don't know what your thoughts are is the guy is in the ER, systolics of 70s, but it's transferred to the CCU where time and hours that we're losing with 3 vessels on board. How do you tackle those in the context of time and shock?
I mean, so this is a patient that's more acutely ill than the previous one.
Right.
So I don't think you don't need to be too smart.
Okay.
And so this needs more attention. And he's very tachycardic, very hypotensive, and I mean, I think this is so I think this should go clearly into more support than. I was going to make a comment in the previous case that, we went to dinner last night. Before we had the steak, we had an appetizer. So there is a progressive increasing. So, you do the balloon pump and then you put a more severe device because while my colleagues sound like they are very happy doing it and everything is simple, you buy more complications and the risk is a little higher. So it's not as simple as it sounds. So in general, you want to do something that's simple and then you progress. But this patient, probably we would skip the appetizer and going to the entree, which means probably a more sustainable form of support. So I think that I would be very aggressive and maybe call Brian or Eddie and do something more than the balloon pump.
We're gonna pin you down a little bit. What do you want to do? So we have options. I'll listen. Purple AV ECMO, take them to the cath lab, put in an IMPELLA, maybe CP, call Eddie for a graft or an
So is he intubated already, or?
He's intubated.
And what are his blood gases?
He's a little sick.
His blood gases.
Is he like in 100% FiO2?
No, he's not 100% FiO2.
You can tell me it is, and then it's easy. So my algorithm would be, right? So if he was in severe respiratory failure as a consequence of heart failure, I think AV ECMO would be a very good choice.
No, after intubation, his oxygenation improved. He's on 40% FiO2, but 10
Oh,
of
he's still like in 80 or 100, but still, okay. So if he was in acute respiratory failure, I think I'd say AV ECMO. On the other hand, if his respiratory situation is stable, I think you can probably put an IMPELLA 5.0. You could do tandem heart, but he will be in IMPELLA 5.0.
To time out, I tend to disagree with that. Well, first of all, the IMPELLA 5.0 would be a beautiful thing to use if you can get it in there. But remember, this is a trip to the operating room, general anesthesia. We got to do a surgery, even though it's relatively minor. There are risks involved, and blood pressure like that, anesthesia, and 3 drips, they're all going to freak out. The patient needs to go straight to the cath lab. You do put in a percutaneous device from the groin, like a tandem heart or CP IMPELLA, in my opinion.
Brian, you oversee our ECMO program. You're the ECMO police.
Yeah. It's just not,
Peripheral AV ECMO, because he's hypoxic, his CVP is 20. I don't know if that left side of his support's going to do the trick.
Well, I mean, first of all, bridging off ECMO is not the greatest strategy. Well, you have to. I mean, just because you can put something in doesn't mean it's the right thing to do, now does it? You always have to be thinking exit in the back of your mind.
We need time to have medical review board to talk about
And journal club and all that, understand. So you could, okay, so you could make the argument, especially if the patient has that sat on 100% on the ventilator, you could make the argument to put in a peripheral AV ECMO, stabilize the patient. Yes, we could do that at the bedside, but that's not the scenario here. You're giving me the worst case one. No,
But I mean,
his heart rate is 120.
No, but I say his oxygenation is.
His oxygenation improved, but he still has biventricular failure.
Yeah,
his
but
CVP
if he's
is up to 20. His so.
You got to.
If you take the patient to do a 5.0 IMPELLA, say he can make a trip.
No, it's, yeah.
RV is going to sustain it, but the 5.0 IMPELLA is going to be like that.
Yes, so if he's in worse shape, we could do a peripheral AV ECMO, do journal club discussion, and then we could potentially do a 5.0 IMPELLA, right? And that would be like a vent, decompress the LV. We can maybe transition that depending on his RV function.
So, Dr. Drasner.
Go ahead.
Yeah, no. I mean, obviously hard to say. I think the two parameters to swing us more towards ECMO is the oxygenation and the severity of the concomitant right ventricular failure. So I think for someone like this that has a high right atrial pressure like that, if that's true, we would lean towards going towards ECMO just to buy us support and also to avoid the potential of anesthetic complications where we've had arrests when we've taken them down and tried to put 5.0 IMPELLAs in. So we probably would go we'd probably go ECMO at this point.
Yeah, no, he's on 3. He's on norepinephrine, dopamine. Yeah, dobutamine, dopamine, and norepinephrine.
The other thing is this is an acute presentation. I'm not sure yet. I'm not sure we saw the data yet. Could this be fulminant myocarditis? And it's fairly young. Could he recover?
Yeah,
this is a pretty acute presentation. So
I'll give you
I'm also
that
thinking that.
data.
I also want to point out that what you do is all depends on what kind of place you are at and who the people involved. Because you guys are willing to come in the middle of the night and put in a 5.0 IMPELLA. I go to all the centers where they say that, the surgeons are not willing to come in.
Well, are you willing to come tonight to the cath lab?
That's an excellent point. So you want to tailor the device, not only to what you think the patient needs, but what's part of your armamentarium, what you have expertise in.
The center expertise.
But in general, I think when the patient requires ventilatory support, I think that most likely you'll be very safe with AV ECMO. I mean, I think you can do others, but AV ECMO will guarantee you, will give you time, and the patient will survive. And then later on, you can make some other decisions. You know, there are, you know, our former colleague, they have a series of over 200 patients of an ECMO with similar, I don't think they've published it yet, but they, similar situation, and maybe even less sick than that, with a success rate of over 50% and survival or bridging to some other form of therapy. So, you know, I think that, as you said, probably the level of experience and the speed in which you can do it, but maybe ECMO will give you control of every other parameter that you need here.
The outcomes oversight. You know, we're metric-driven medicine. We always talk about cutting down the mortality by saying no to patients, and that's something like we had a time when our mortality outcomes were bad because we were able to put it in a lot of people. People who are in cardiogenic shock with their heavy ECMO, their mortality is high compared to others.
Yeah.
Ask for Mike if you're going to talk.
Oh, they couldn't hear.
So Dr. Brimaraj's point is, you know, there's ELSLO benchmark and AV ECMO registry data. There's institutional experience in terms of what's futile, what's not. Institutions follow their AV ECMO success in terms of successful bridge to discharge and percentage. So,
go ahead.
Dr. Bruckner, you know that.
So just a few comments about that. As you know, you call me the ECMO police, but the majority of these AV ECMOs are putting in heart failure patients are undergoing CPR. So that's a big problem, and it's clearly been shown in studies and even our institutional experience that mortality is extremely high, about 95, 99%, almost 100. But if you catch them early like this, and they're in a state where you can preserve them, stabilize, and then do some other bridge therapy, I think that's the best way to go. But don't lump them all in together, because the majority of these AV ECMOs replacing are under CPR. In fact, I just got consulted on one right now in our own ER. And CPR.
Brian,
Dr. Shine is taking care of that.
Brian, that's a fundamental difference, right? One thing is to use
Yeah.
AV ECMO as to rescue someone CPR.
Yes.
As opposed to use it as an assist device in someone who has shock or refractory shock. It's a big difference.
Yes, I just wanted to point that out. Yeah.
So Ash, take
So
us home.
again, going through some of the labs, you know, he's got end organ dysfunction, hyponatremia, you know, everything which comes with heart failure. Cardiogenic shock. So, so his LV is not that dilated. It's about 5.5 centimeters, and it's barely moving at all. And even the RV is not moving much on the echo. So we placed a Swan-Ganz in the CCU. Again, mean CVP was 20, RV was 62 or 20. Wedge pressure was 26, PSAT was 47, cardiac output of 3.2 with a cardiac index of 1.6. And then, you know, we also biopsied him and...
Much later, we biopsied him much later.
much later. This was when we had taken him to the cath lab. So I think we already talked about this in terms of, you know, what would we do. So... Again, going through some of the key aspects of MCS, I think the big thing, like we talked about, was timing. You know, early initiation of mechanical circulatory support is important. Again, level of support, you know, whether it's providing adequate perfusion to all the organs. And thirdly, prevention and management of potential device-related complications, whether it's device malfunction, infection, or bleeding. I think, you know, these are the three things that we try to, you know, optimize so that we get the best outcome for the patient.
So what did you do?
So yeah, I'll get to it.
Oh,
The suspense is killing us.
okay.
We're still in teaching mode.
I thought that you were wrapping up the discussion.
So just you know, to go over some of the devices, you know, this is 2.5 and this is the CP and this is the 5.0. Essentially, it differs in the amount of support it can give from 2.5 liters. The other one's about 3.5 to 4 liters, and the 5 is gives you 5 liters of support. And this is the 5.0 IMPELLA that we're all talking about, where the surgeons can sew in a graft and put it through the right axillary artery, and it goes into the LV. And again, the IMPELLA 5.0 really provides robust hemodynamic support. As you can see here, as we go up on the speed, you can get higher flow, higher blood pressure, and your wedge pressure decreases. And again, similar with the tandem heart too, that as you increase the speed, your CVP and the wedge pressure, everything decreases. So. In terms of the evidence for all these assist devices, that's very, very limited. I think what we know as a take-home is that there's definitely an improvement in hemodynamics, but in terms of survival, there are really no studies out there which can show a survival benefit when compared to a balloon pump. Of course, these are all small sample size, and even in these patients, some of them have had crossover because patients who've failed on balloon pump, they've been crossed over to the other arm. So it makes it really hard to actually design a good trial. And this is all the data with the IMPELLA. Again, as you can see here, there's a difference in the hemodynamic benefit. So your cardiac output increases, but again, when you look at 30-day incidence of major adverse events or death is just not there. Now, this was a non-randomized single-arm study again, which showed that the survival was really good with patients who got an IMPELLA, but again, it's not a randomized controlled trial. Now, again, this was just recently presented where they looked at the IMPELLA CP in patients with STEMI with cardiogenic shock. Again, the outcome was 30-day mortality, and there was no difference seen in patients who are randomized to balloon pump or the IMPELLA. Again, even at 6 months, the mortality was fairly similar. But these are all really sick patients, and patients going into the trials already had so much end organ dysfunction that it's really hard to tease out the difference. Now, in this study, when they looked at patients who would never have been a part of any randomized controlled trial and teased them out, when you took the patients who would actually fit the bill for any other STEMI randomized control trial, in those patients there was a benefit. So again, these are all small numbers. So this kind of drives home the point here. When you look at the cardiac index, mean difference, mean arterial blood pressure, all of them improve, wedge pressure decreases, but mortality is really not there. So just a couple of words about ECMO. Again, like we've talked about, the big thing is that it can give you biventricular support and also give you oxygenation. I think the peripheral AV ECMO circuits have been improving, and I think these the newer peripheral AV ECMO circuits are really good in terms of being able to put it at the bedside. You can really provide, a return of spontaneous circulation within minutes. I think that's the key, because everything else, whether it's tandem or the IMPELLA, you need to transport the patient to the cath lab or to the OR. And in terms of its ability to be put in right away, it's just not there. Whereas with ECMO, you really you can easily buy time. Now, this is a pressure volume loop, again, showing that with, ECMO, it will definitely give you that stroke volume benefit. But one thing to really keep in mind is that it does increase LV load. So your wedge pressure and your LV EDP increases with ECMO. So we have to think about some kind of LV unloading strategy. Otherwise, I think pulmonary edema is a big problem with these patients, and they end up getting a lot of lung injury and being unable to bridge to anything else just because of that. This essentially, talks about that. Now, this is another newer thing, which there was one study which just got recently published from the French group, where they've started to put, ECMO plus IMPELLA to really provide robust LV unloading in the presence of ECMO. This mainly came about because there was a study which looked at ECMO and balloon pump, again from the French group, which showed no mortality benefit. Even though there was a hemodynamic benefit, it didn't show mortality benefit. Whereas with this small study that they published out, I think, on 55 patients, there was mortality benefits in this ECMO PELLA patients. So again, I think just to go over, summarize all the devices available, I think from lowest support to most robust support. Again, as you can see, you require bigger French catheters as you kind of go up the support. And if you look at the FDA approval, all of these devices are really approved for very short duration of support, even though we end up keeping these things for much longer period of time. Again, not to forget the risks which come with this, whether it's the leg ischemic risk or the bleeding requiring transfusion. So you can see with IMPELLA, tandem heart, peripheral ECMO, all of these, they do have a much higher complication rate. And this is just to I think we need to put this in perspective when we are thinking of really balloon pump versus something else. If you have a patient where you can actually get by with just a balloon pump, I think that may not be an unreasonable first option, since the adverse event profile is much better. Again, there are certain contraindications with balloon pump and IMPELLA and tandem heart. As we can see here, severe peripheral vascular disease is really a contraindication for all the three of them, and aortic regurgitation is a contraindication for IMPELLA, though we've gotten about a couple of patients through with even IMPELLA, even with moderate AI. And again, presence of a thrombus in the chambers of the heart can be a contraindication to either IMPELLA or tandem. Skip this slide. It's not letting me, but okay. So back to our case, I think we put in a tandem heart, and like I said earlier, we had biopsied him. We did not find any giant cell myocarditis with him. And then we eventually transitioned him to a durable LVAD and subsequently transplanted.
Excuse me, was that tandem heart placement during the day, light hours, or
Yeah, this
on
was
a weekend, midnight?
pre-IMPELLA 5.0, pre-CP.
Yeah.
So we had at our,
In all
Brian,
cases.
you and I talked about AV ECMO versus tandem years back, right? In terms of what we had at our available. But concerns, his oxygenation improved some on the vent, and we thought it was largely right-sided heart failure from left-sided heart failure. So with LV unloading, he actually was stabilized.
Yeah, he stabilized, and his right-sided heart failure kind of got better just with tandem heart.
And you can also add an oxygenator to that tandem heart circuit.
You can. That's an advantage with
It's
tandem
another
heart.
thing, if you can get him into the cath lab, you can always add that on. We've done that.
And so he's doing well after transplantation. So again, I think to drive home the point, I think it's important to identify cardiogenic shock early. If you can identify in the pre-cardiogenic stage where you have hypoperfusion without hypotension, that is ideal. But if you let them go to the refractory cardiogenic shock stage, honestly, I think most of the trials have looked at these patients who are in severe refractory cardiogenic shock. I think just putting mechanical circulatory support is not going to do the trick here, because most of if you look at the risk models for severe cardiogenic shock, the most robust predictors are predictors of inflammation. RAGE, IL-6, all these things actually predict much better than any of the hemodynamic predictors. I don't have that slide, but the AUCs are like 0.9 versus 0.6. So I think if we don't address the underlying inflammation in some way, I think just attacking the hypoperfusion with a mechanical circulatory support may not do the trick. So again, I think one of the things I wanted to emphasize here is that there's a team approach needed, where you have the surgeons and the heart failure doctors having general club and talking over about it. And it includes the intensive care unit and the cardiac catheterization laboratory. And our team structure and sort of the shock algorithm here is when patients have cardiogenic shock, we talk, and then we decide whether you have a refractory cardiogenic shock or you're still treatable cardiogenic shock, and then decide whether we go to a balloon or whether use peripheral AV ECMO versus something more durable upfront, such as IMPELLA 5.0, and then to something more durable, such as an LVAD or a transplant. And again, this is some of the things that we made comments to here in terms of whether somebody would be a candidate for destination therapy or bridge to recovery or to heart transplantation, depending on either their response to temporary MCS. And I think that's one of the good things with development of so many temporary MCS devices, that we are able to actually offer them robust support, but at the same time, we could use these as sort of bridge to decision. And you don't have to use surgical VADs like thoracic PVADs, which were used earlier, or centermags as a bridge to decision, but something less invasive, but with the same amount of support to use this as a bridge to decision. Well, thank you very much for your attention.